Ready for part 2 of chemotherapy? Just a quick review. We're talking about chemotherapy, that it's cytotoxic, meaning it's destructive to cells, and it's not destructive to all cells. It specifically targets proliferating, which means reproducing rapidly, cells that reproduce rapidly or multiply like rabbits, which is what exactly cancer cells do. But we also talked about other body cells that proliferate rapidly, specifically the skin and hair, the bone marrow, and the GI epithelium. Let's recall the bone marrow, RBCs, WBCs, platelets. All of those are going to be depressed when we're on chemotherapy, and we talked about anemia with RBCs, risk of infection, and risk for thrombocytopenia. Before we move on to our next classification of chemotherapeutic agents, let's look at a couple of sample questions regarding bone marrow depression. The nurse caring for a client receiving chemotherapy and determines that the client has developed myelosuppression. Myelo, again, just means bone or bone marrow. Which lab value would support the client's diagnosis of myelosuppression? We have a protein, 7 grams. We don't know whether that's out of normal range or not, but we don't care because protein has absolutely nothing to do with myelosuppression, right? How about magnesium? Nope, not made in the bone marrow. Hemoglobin, yep, we're made in the bone marrow, right? Hemoglobin is the RBCs. And then our last choice, BUN, blood urea nitrogen, has to do with kidney function. So without even knowing any of the normals, abnormal lab values, I'm going to go with hemoglobin because that's the only thing that's affected by the bone marrow. And in fact, yes, that is correct. And here's our rationale. And it's because those are in fact low. We normally want the hemoglobin to be up around 13. Depending on whether you're male and female. Males, the normal for hemoglobin hematocrit is a little bit higher than females. Let's take one more question here. The nurse is analyzing the laboratory results of a client with leukemia who has received a regimen of chemotherapy. Which laboratory values should the nurse note as a result of massive cell destruction that occurred from chemotherapy? Okay, this is a little bit different. But I want you to look at something here in our choices. Let's pretend that we hadn't read the question, and let's look at this. Anemia, decreased platelets, increased uric acid level, decreased leukocyte count. Do you see what 1, 2, and 4 all have in common? These are all resulting from bone marrow suppression, right? Anemia is decreased RBCs, decreased platelets, and then decreased leukocyte count would result from decreased WBCs. So without even reading the question, you could play the Sesame Street game of one of these things is not like the other and go with the increased uric acid. And in fact, that really does answer our question. Massive cell destruction, you're going to have that because all of these cancer cells are hopefully dying and they don't just evaporate. They got to come out somewhere, right? And so they come out in our urine. And so increased uric acid level is indicating that we have a lot of cell destruction. We got to watch that. And here's our rationale. Hyperuricemia is especially common following treatment for leukemias and lymphomas because of the high kill amount. Okay. Our next classification of chemotherapeutic agents are the alkylating agents. And if you're following along in your book, which I hope you are, highlighting some stuff, we're on page 223. We've already talked about antimetabolites. Now we're to alkylating agents. These are perhaps some of the most feared and most misunderstood, in my opinion, and I'll explain why later. Alkylating agents are sometimes called non-cell cycle specific. Antimetabolites are cell cycle specific. They attack the cell in a specific phase, the S1 phase. Although it's not in your book, you don't really need to know that, but antimetabolites work in the S1 phase. Alkylating agents interfere with the DNA of a cell, and so it works in all cycles of the cell. It's non-cycle specific, and because of the way they work, they cause some additional side effects and problems that some of the other chemotherapeutic agents do not. We have our typical, our skin and hair, bone marrow suppression, all the GI stuff, and I even put a mouth here to remind you that it's not just the stomach that gets affected, it's the oral mucosa, the anal mucosa, all of the whole entire digestive tract is lined with rapidly proliferating cells. Some other things that are specific to alkylating agents are a risk for infertility and future leukemias. And this one really stinks because this is a type of cancer too. And unfortunately, one of the worst side effects of using alkylating agents, which you have to use to treat the cancer that you have, is that it can increase your risk for developing a different kind of cancer in the future, especially leukemia, because this interference that it does with the DNA is sometimes permanent. And that's why it can also lead to infertility, which is also a permanent condition. So these are not fun things to use, but you know, they're used because they are effective and people don't want to die. And so this is sometimes the best way. Cisplatin is the first one we're going to talk about. And another specific side effect with cisplatin is, if you can tell what this is, just popped up in my side effect zone, is an ear. And this ear is very damaged and injured, and cisplatin is notorious for ototoxicity. Remember how we talked about that? Especially if it's being used in combination with something else, like what some of the antibiotics that we talked about in the antibiotic chapter, and some things like aspirin and Lasix, which are known to cause ototoxicity in high amounts. Ototoxicity is a major problem with cisplatin, and hearing loss that results is going to be permanent. It's not something that's going to come back. Another type of alkylating agents are the nitrogen mustards, and this is where I feel that alkylating agents get most misunderstood, because when we hear the term nitrogen mustards, it conjures this image in our mind, right? This is World War I. Nitrogen mustard was weaponized, and people had to wear these creepy masks, and we just automatically think of world annihilation and horrible things when we hear nitrogen mustard. But it also has medicinal purposes, and we're not going to use it in the strength that they use when it's weaponized. Totally different thing. Same substance, just used in a different way. So two of the most common nitrogen mustards are cyclophosphamide, also called Cytoxan, and ifosfamide, more commonly known as Ifex. And again, they're going to interfere with the DNA. That's why they work so well as a chemical weapon, make people pretty sick. And one thing that the Cytoxan and Ifex are notorious for is, this is, if you can't tell, why do you hate me? This is the bladder. One of the best cartoon bladders I've found. These can be very toxic to especially the urinary tract system, but the lower part, the bladder, rather than the kidneys. I mean, it can do nephrotoxicity too, but it seems to target more the bladder. And hemorrhagic cystitis is what it's called, because again, it's affecting the bone marrow, so once bleeding starts, it's hard to control it. There is a medicine that's been developed called Mesna, and some people think Mesna is a type of chemotherapy because it's always given with chemotherapy, but it's not. It's a kind of like the one that we were talking about, leucovorin. It's a rescue agent, and Mesna is usually given, especially with Ifex and sometimes with Cytoxan, to reduce the side effects of hemorrhagic cystitis, and it does a very good job of it. Protects the bladder. We're also, when people are on these type of things, we do a lot of pH checks on their urine, and we make sure that their pH doesn't get so out of whack that it causes permanent kidney damage. So that's one thing when you work on a chemo floor you do a lot of is pH. You have those little strips, and you test every single urine specimen and make sure that the pH is within a safe range. Before we get to our next category of chemotherapy, let's look at some sample questions over alkylating agents. Here's one. This is caring for a client who's receiving cisplatin. That's the first one I talked about under alkylating agents. Which adverse effects are associated with this medication? Select all that apply. I like the select all that apply. Those sometimes strike fear into people, but I think they're sometimes easier. So tinnitus, ototoxicity, those are both the same thing, and they have to do with our, remember our picture of our ear with the bandages all over it? Yeah, definitely associated with that. Hyper and hyper, I don't care what they are. No one's going to be hyper anything pretty much when they're on chemotherapy. Everything's low. So I see a hypo something down here. I'm going to check that because chemotherapy knocks a lot of stuff out. And let's look at this. Nephrotoxicity, well, we had a picture of a sick bladder. Bladder's pretty close to kidney, so I think that's probably a good choice too. Let's see, and sure enough, we were correct. And here's your rationale. Here it's again repeat cell cycle phase nonspecific, affect the synthesis of DNA, autotoxicity, all of those things that we checked. Let's go to question 13, which is on cyclophosphamide. This person's taking cyclophosphamide for breast cancer. Important instruction: take medication with food. I don't know if it needs to be taken with food or not. Increase fluid intake to 2,000 to 3,000 milliliters daily. That sounds like a pretty good choice to me. Decrease sodium. I don't know. Increase potassium. We didn't talk about any of that. We did talk about how it is very toxic to the bladder and how this is the best way I know of, even when you're not on chemotherapy, to protect your bladder, is drinking lots of fluid. And yes, we are correct. Here's the rationale. Again, we're talking about that hemorrhagic cystitis is a toxic effect, and so increasing the fluid intake is important to protect that bladder. Here's a very similar question. Again, it's about cyclophosphamide, and it's about hemorrhagic cystitis. It's just phrased a little differently, and I look here and I see right here increasing the fluid intake again. And so that's just a different phrasing of the same thing. And we're good. Let's go to question 26. A client is diagnosed with testicular cancer and is prescribed cisplatin. The nurse should monitor for which toxic effect of this medication. We have nausea, tinnitus, vomiting, and leukocytosis. They're going to have all of these, right? Nausea, vomiting, go with any chemotherapeutic agent. Leukocytosis is going to go with the bone marrow suppression. But with this, in this case, the tinnitus is the one that's more specific to the cisplatin. And so that's what we're going to monitor most for, because we're going to kind of expect all of these. Here's a question about IFEX, which was not included in your textbook, but it's probably one you need to know. And ifosfamide sounds a lot like cyclophosphamide, so it's kind of easy to remember. This patient has cancer of the testes, taken IFEX. The nurse anticipates that the client will be prescribed which additional antineoplastic medication. That's a little bit, that could throw you off, but we'll go through them. Cisplatin is just another chemotherapeutic agent. Melphalan, I have no idea what that is. Mesna, that's the thing that's going to protect the bladder, and it's often given with IFEX, so I'm going to go with this answer. Prednisone is sometimes administered along with chemotherapy too to reduce some of the side effects. It can help with nausea, and it can also help with swelling. But yes, Mesna was our right one. And again, here it's encouraging you to drink a lot of water, and hemorrhagic cystitis is what we're trying to help. I guess this other medication is, it doesn't tell us what that's for. Here's kind of an obvious question, since we're talking about, oh, well, maybe it's not so obvious. A client with breast cancer is being treated with cyclophosphamide. The nurse plans care knowing that this medication fits which classification? Anti-metabolite. No, that was our previous one where we talked about methotrexate and Ara-C and 5-FU. Hormonal medication? No. Cell cycle phase specific and cell cycle phase nonspecific. Again, you'll have to remember that cyclophosphamide is an alkylating agent, and those are cell cycle phase nonspecific. That's why they have a few more side effects than some of the others, because they interrupt the DNA. And one of the last questions I could find on alkylating agents was, again, talking about cyclophosphamide, and here we go. It should be obvious. This is the third question that's been just phrased similarly. It's increasing the fluids because they're hard on the bladder, right? And we are correct. And if you need to see the rationale once more, and so if you took anything from this, you need to connect cyclophosphamide with a lot of water, cisplatin with a lot of water, and Mesna connects with these medications, and also that there was a couple talking about autotoxicity, tinnitus, that sort of thing. And next we'll cover mitotic inhibitors.